Hello, welcome back to Favaloro Foundation University Hospital in Buenos Aires, in Argentina. Thank you again to Mainstream for having us for this terrific educative project. So it's here with me on my right side, Dr. Lev Franco, who is our fellows, our technicians, Kevin, Hernan, Matias, Lorena is a technician from Medtronic. Behind the screen is Gustavo, Alberto, and Claudio. Carmen Gomez is our doctor anesthesiologist, and Mariano is the anesthetic tech. We have prepared, I think it's an interesting case for today. We will present the first slide. So this is a case for TEVAR. This is the title. Next. So she's a very young lady, 52, with chronic type, actually A, aortic dissection with severe aortic dilatation on the thoracic aorta with more than 6 centimeters. I say A because it was repaired. So she suffered from the Marfan syndrome. She had a type A aortic dissection 10 years ago. She underwent surgical repair with aortic valve sparing, with Tyron David procedure, plus ascending an aortic arc replacement with an elephant trunk using the burst technique according to the surgical team description. She received an ascending aortic graft of 30 millimeters on diameter with the aortic arc of about 24 and an elephant trunk of 24 and also 24 in length. So she remained with a chronic type B, but it's actually a residual type A aortic dissection under clinical management for almost 10 years. And she did really well until the last control where we found a significant dilatation of the thoracic aorta. So she also had a significant or severe thoracic deformation you will see on the CT scan, and she also suffered from an infection disease and when she was young, with the remaining bronchiectasias in his pulmon, in his lung, sorry. Next. So the HCG is quite normal, but with the first degree AV block, probably after the surgery. Blood test a little bit anemic, with nothing special about there. With the body mass index very low, she is very thin, very short. And on the echo Doppler, she is also under clinical follow-up because she is suffering from significant aortic regurgitation, with a mild mitral regurgitation with a preserved left ventricular ejection fraction, totally asymptomatic. So it was an important point because for the HAR team discussion, it was this issue considered to, suggest this TEVAR procedure instead of reoperation. She doesn't have any frailty characteristic, and of course the procedure is not futile. Next. So this is the CT. You can observe there the significant, thoracic deformation with the pectum excavatum, a significant pectum excavatum. It's really, astonishing when we observe this thorax and how she underwent the surgery. You can see there that the distance between the posterior face of the sternum is about 6 or 7 centimeters from the anterior vertebra. Next. So there we observe the significant dissection after this elephant trunk. We made some measurements. The diameter is according with the surgical description between 24 and 28 with a length of 2.5 centimeters. There is an indentation there that nobody knows exactly what is this or what is producing this finding on the CT scan, but it's probably surgical, remaining of something related with the previous surgery and the connection of the graft. Next. We observed there, in the previous slide, that we have at least 3 flaps there, or 2 flaps there, It's an helical flap with significant deformation of the aorta from the very beginning with the significant angulation also in the zone 2, between zone 2 and zone 3. Next. So there is with a little zoom where you can observe probably we have a landing zone between 2 and 3 after the subclavian of 2 centimeters. Our idea is to go exactly between this indentation and the subclavian artery. We will discuss then with Dr. Lev next. There you observe the severe dilatation of the aorta, which is the indication of treatment after 10 years. And on the right of the panel, the significant also scoliosis of this column. And there is significant communication between the through and the false lumen there. And anyway, this is the indication of why we indicate this treatment after 10 years of being asymptomatic. Next. There is quite a 3D reconstruction where we observe this flap with a significant communication in the proximal part, probably in the distal landing zone. There is a significant reentry that we will try to seal, not only the entry tier distal to the subclavian, and then also the distal reentry near the celiac trunk. Next. So on the previous slide, what we observed that the aorta distally to the dissection is 28 or 29 millimeters. So this is important for the device that we are going to use distally. Next. So this is the vascular access. The right femoral artery is quite normal, straight without significant calcification, with a good diameter, almost 10 millimeters. Next. So this is a 3D reconstruction of what we observe with this dilatation, especially in the aortic, I mean distally to the aortic arc, but continuing until the transition of the thorax and the abdomen. Next, so this is 20 centimeters. Probably we have to cover a little bit longer than 20 due to the angulation. So in summary, it's a young lady with previous ascending aortic arc replacement, complicated with severe dilatation of the thoracic aorta, with severe asymptomatic aortic regurgitation, and the heart team discussion, with especially with the surgical group. They decided to try this endovascular procedure as the first option instead of considering any other hybrid or open surgical repair. Next. Proxima. So the strategy that we have already planned was the percutaneous access with the left subclavian preservation if we can, but we are going to go aggressively. We are going to go almost over the subclavian ostium. And then the plan is to implant probably 2 thoracic endografts. Next. So the landing zone that is supposed to be there between 2 and 3, where the elephant trunk or surgical elephant trunk was deployed, and where we have to reconnect with the descending aorta. Next. So this is for other situation or something that we have discussed. We had to do something surgical to I mean, preserve the subclavian artery. So the idea is that it was not necessary. Actually, we can comment then with Dr. Lev that we have a long experience and we have covered many subclavians and we haven't protected most of them. And to be honest, we never had a problem for covering the subclavia. When we have paraplegia or paraparesis or something like this, it was related to thoraco-abdominal reconstructions and not to the subclavian artery. Next. Probably the other option for this patient would have been something like this, a complete debranching from the ascending aortic graft, and then a TEVAR from the zone 0, covering the whole or the whole aortic arc, and then all the descending aorta. But we think that we can go with this minimalistic approach, trying to fix it there on the elephant trunk. And if we fail, but we can fail, the idea or the discussion that we have with the surgical group was, if we have a residual significant endoleak, probably this patient is going to be surgically repaired in a way like this. So, but due to all this thoracic deformation, we preserve this option as an option B or rescue in case we fail today. Next. So probably more recently in our surgical group, what they are doing with this type A aortic dissection, compromising the aortic arc, is a surgery like this, introducing some new graft like the beta graft, which has a longer elephant trunk, which is stented and is much more easy for reconnecting, and not the situation like we have today. So next, so this is the case, and I can ask Gustavo about the case, and then we can discuss about what we have already done.
Well, thank you, Oscar. It is a very interesting case. We can point out that it's a very young patient. Usually this kind of patient with connective tissue disorders goes to surgery, but in this case, it's a very high risk surgery patient. So with a 60 millimeters diameter, aortothoracic diameter, a huge tear at the descending aorta, only one tear, and with a high flow inside the false lumen, I think that the best option is to treat it with TEVAR. And of course, if we have an endoleak, most of this patient has between 20–26% of endoleaks. We can match a second option with another endovascular treatment from the ascending aorta, and with a TEVAR, perhaps. And well, perhaps we can avoid surgery that is very important for these kind of patients.
So for those who are not so familiar with the aortic dissection, or for the type A aortic dissection, most of the patients need a second intervention during follow-up, especially during the 3 or 5 year follow-up, like the INSTEAD, the Mother Registry, and many others from the Valiant or the Medtronic device follow-up. For the acute aortic dissection, which are intervene endovascular or surgical, almost 40% of the patients need a second intervention after the 5-year follow-up. Here, we are at 10-year follow-up. So she actually did very well. But now we have significant elements to decide why we should treat this patient. First is the diameter of the descending aorta that we have already mentioned. Then is the diameter of the false lumen, which is more than 4 centimeters. It's another indication, even if patients are asymptomatic. So we have already planned was to put a 7 French introducer sets on the left femoral artery. We have put here a pacemaker for pacing for deployment. And then we did crossover, and we can show what we have already done and what problems we faced. There is a crossover with the pigtail. She has very normal artery. It was very easy to cross. Next. Then we put the pigtail to do a puncture. Next, under fluoro guidance. We select the entry point near the upper part of the head of the femur. Next. So we have decided to put the pre-close. We have used ProStar. This is gonna be could be a discussion point because many people like to use ProLite, like Dr. Lev. He likes the ProLite, and I like to use the ProStar when and I am using over the 18 or 20 French sheath size. Gustavo, what are your familiar? You like more the ProLite instead of ProStar, even for these cases?
It's easier.
It's
So
easier.
yes,
Yeah.
it's easy. It's more easier, and we are more familiar. The new generation. Sorry
Yeah.
for that
Thank you
word.
for calling me old. Thank you, Gustavo.
We are more familiar with
Yeah,
that.
yeah. I understood. Yeah.
I'm sorry.
So yeah. Next. Next. Sorry. On the previous view, we have problem because our plan was to put the 6 French on the left radial artery, but it was not possible, probably due to some trauma for the previous surgery. The radial artery was very weak, the pulse. So we couldn't get in even in the cubital artery. Gustavo is very familiar with cubital, but we couldn't. So finally we did a puncture here. If you show my left hand behind the arc here. So we are on the humeral with the second 6 French introducer set, as you can see there. Our plan was to put the pigtail there for control, for angio control during the deployment of the graft. But we have to use a different catheter because the following. Next. So when we put the ProStar, next, Proxima. Next. Here, it's important to see when we pull the needles out, it's important to see that the 4 needles are coming into the set of the device and not outside, because if not, it's almost impossible to retrieve the device. Next. After that, there is the maneuver. You see the needles coming into the device. After that, I have 4 needles here, 4 threads here that can be moved, as you can observe here. And then the difference with the ProLite is that we have to do the knot in the surgical way before the final of the procedure. So after we put the ProStar, we put the 11 French sheaths here, and we try next to go into the ascending aorta. So you can observe there a wire from below, which was impossible to find the true lumen. So we introduced a SIM catheter. A SIM was 1 or 2, 1. So we preformed the catheter in the ascending aorta, as you can observe there, and then we pulled the catheter back. The tip of the catheter was inside the distal elephant trunk, and so we advanced a hydrophilic white wire distally. Next. So with this maneuver, we are absolutely sure that we are inside the true lumen. Next. And then we introduce a snare from below. We snare the catheter. Unfortunately, we didn't show that I rotate the catheter to pointing out the snare, which was difficult to handle the snare, and it was much easier to handle the catheter from the brachial axis. We snare the wire, we pull the wire, and we introduce now a pigtail. So we have a rail from here, from femoral to the humeral size. We have the 2 wires here. This is from radial, and this is from femoral. Through this rail, we introduce this pigtail, which is now on the next, on the ascending aorta, and we are sure we are entering into the true lumen. Next. Sorry. Here is how we advance the catheter from below, and we pull the other catheter. We went into the subclavian, and then we connected the catheter a little bit more. Next. And we push everything to be sure that the pigtail catheter is into the ascending aorta. So now I think I am ready to pull the rail. Hopefully the pigtail stay there, so we can do the angio and then put the stiffer wire. So I will release the wire from here, from the femoral side, and I will pull from here, and I will pray. Sorry, let's go to the left oblique. So we are sure there that we are on the ascending aorta. Is that correct?
Yeah.
Okay, so now I am pulling the wire. I give to Gustavo and Franco. The wire is out and the pigtail. Keep the wire because we will need it to put the pigtail here. Give me una llave 3 vías. Okay, stop clock here. So we have the catheter also on the ascending aorta. Probably we will share in a second the fusion of the CT image with the angio image. So let's test. Okay. So here, a little bit more panoramic. Something like this. Okay, she's very small, as you can observe. Compensate. ¿Puede no respirar, Carmen? ¿Puede no respirar? Stop breathing. Okay, and let's go with the angio. It's perfect, beautiful. So stop the angio there, and we can observe here some important findings. First, that what we thought it was the true lumen in the inner part of the aortic arc is not that true. And as you can observe there, the tube is a little bit longer than expected. So probably we don't have to go too far distally against the subclavian artery. Do you agree on that?
Yeah.
This is the good thing.
Yeah.
The bad thing is when you have such a long elephant trunk, sometimes would be extremely difficult to advance the TEVAR device. So anyway, we have to do it. We have to try. The other possibility is to do a rail from the right subclavian, but it could be very traumatic for a patient with this kind of aorta. You also observe there the significant aortic regurgitation, and we will have to bear in mind because, of course, we are going to be asked in the future about TAVI in this case, and it sounds a little bit extremely difficult. So now we will introduce here the shade wire, and we will put the pigtail, and then no, dame la otra, la J. So we have decided to use, okay, this is, no, this one. A device which has a free flow in the proximal end. So the reason, sacalo vos, Gustavo, que se me sale el introductor. And the reason why we have decided, why we have decided to use this device instead of the others without free flow in the proximal end is because for the Medtronic device, the deployment is much more precise when you have a distal free flow, because you can start deploying the device, keeping the free flow still attached to the delivery system, and when you are ready, then you deploy the proximal part. If you use the non-free flow device, the opening is totally different. It's like a self-expanding stent. And in this, in such angulated aorta, probably the deployment would be not or not too much precise or as precise as we want for this case. So the device we have chosen to begin with is the 32 by 200. Okay, so we will prepare the device and then we will introduce the wire. Okay, and then we have to pull the sheath out, and we are going to go sheathless. Let's go with the device. Sí. Okay.
Are you going to insert
Yes,
the
please.
the catheter in the celiac trunk?
I think we
Right
can put it afterwards because it's a good comment. Dr. Leve asked me about marking the celiac trunk. It's something that we are going to use for the second device, because as you can observe there, 10 centimeters is going to be still on the curve of the aorta, and the next probably 10 centimeters is going to be still into the thorax. So from our text point of view, if you can share the image of the CT reconstruction, the fusion of the CT with the ancho images, it's going to be great for the audience. Is the right panel, the right low panel in our monitor? Not the fluoro, but it's a 3D reconstruction. Exactly, perfect. So where you can observe from the left subclavian until the mid part of this huge dilatation is 10 centimeters. 10 centimeters is going to be probably still in the biggest part of the dilatation, and then we had to deploy the second device. For this second deployment, we are going to mark the celiac trunk. So now we need at least 6 hands. So Dr. Lev is holding the wire. Dr. Franco is holding the sheath. I will introduce the wire. Once again, as always, we have reshaped the wire. This is the Landerquist wire, a very stiff wire. We have introduced a second bend, just trying to, configure or adapt to this heavily angulated aorta.
Fortunately, we have two vertebrals dominance, right and left, because the risk of paraplegia is high in this kind of patient. We are going to use two devices with very with with a very good extension.
Yeah,
so
long.
Yes.
Yeah, hold it.
So
so I think what the Dr. Lev is saying is extremely important. You know, for the relationship of paraplegia is with the length of the device you are using, the length of the aorta you are covering, the possibility of preserving the left subclavian has been also shown to be important. And then to prevent any hypotension during deployment and after the procedure. And then also when we are especially treating these complex patients with thoracoabdominal aneurysm, we are change our practice, and what we are doing now is to do in a two-step procedure on a stage. So we usually do the toughest of the more difficult part, deploying the branch device, the branched or the fenestrated device, and then we leave one iliac artery open, and we wait for some days before completing the procedure. So now is the toughest part. Let's put the 15-15 there. The other, you can go there, Franco, to inject. You can go there, yeah. The other important issue here is that we have forgotten to mention if we have introduced a pacemaker. Our idea is to pace in high frequency like a TEVAR procedure, so we can stabilize the pressure or decrease the blood pressure during deployment. Now we are going to zoom to see very well we are landing with this device. So where we have this figure of 8 is where the graph starts. Solta un poquito. So I think we can go there, which was our initial plan, because after delivering, I can pull a little bit to rectify this
Yes.
angulation. Let's inject.
You have the mark
Yeah.
of the free flow,
Yeah.
isn't it?
Yeah. So, I mean,
are you going to
from
put
the 8 to the nose cone is where we have the free flow.
Yeah.
So we are distal to the subclavian. We are perfectly into the graft with a good, overlapping. So I think this is a good position. Yeah. So now this device is released quite similar to the TEVAR procedure. We can rotate for the beginning of the deployment, and then we can deploy a little bit faster.
You push it manually.
Yeah? So Franco, we have contrast. We are ready to inject. Yeah. We can start pacing. 180. Test.
Test.
I am starting there. I will keep it there.
So we are going to pace at 180 per minute in order.
Okay, we can stop there. Stop the pacing.
Pacing.
I think we are okay. We can release the nose cone here. No, we can keep doing. Dale, dale marcapaso. Dale. No way. No repositioning. So, yeah.
Okay. Wonderful. Stop.
No. Paulo. There. Stop.
Stop.
Inject. Beautiful.
Yeah.
Okay, perfect. I am very happy with this outcome. Subclavian is preserved. You can observe there on the floor the pigtail, so only the free flow is over the subclavian. We are perfectly engaged into the distal elephant trunk of the surgeons. We are going to prepare the second device.
I'm going to put another device, thinking in better remodulation and prevent expansion, because with only one device, you close the tear, isn't it?
Yeah, but we have your question is very good, but we have a huge dilatation there, and we will keep having flow there. So it's going to be pressurized. The idea is to seal if we can. Yeah.
Okay.
So now we can stay here. We are quiet now. We can introduce here leave the wire. Gustavo Franco can prepare. We can wait a little bit. We'll introduce the cobra catheter. So to identify what is the celiac trunk. Yes.
You know that there is a registry with more than 12,000 patients, noting that when they compare the risk of paraplegia versus two prostheses, the results were better when they put two prostheses in order to cover all the thoracic aneurysm.
Yes, Franco.
Having less reintervention.
Yes.
And preventing more ruptures.
Maybe AP view, anterior posterior. Let's see, where is the cephalic trunk test?
So nowadays, the trend is try to cover most of the aorta in order not to have more maze
Test.
than putting only one.
So there is phallic trunk test. Pone un poquito oblicuo para allá.
It's very important to identify the celiac trunk in order
Test.
to prevent one of the
Test.
of the causes of paraplegia,
It's
like
there, but I
closing
cannot
the
engage.
celiac trunk or the mesenteric artery, especially in this kind of patients.
Yes. I cannot. Por mostrarme anteroposterior. Yes. So
Of the
this is
renal
the
artery.
renal.
Yes.
Yes. Probably there. Yes.
Ahí.
There.
Yes.
So if we identify where is, we don't need to engage. Let me show you up. Yeah. So we have a huge distance. So if we can mark this vertebra there, it's probably thoracic 12, I think. This is going to be our distal landing zone, upper from here. Test.
Do you think it is necessary to prevent?
Yeah, absolutely. The celiac trunk. Yeah. Test. Also test. But the important issue is to be sure where we are.
Okay.
Mostrame ahora panoramic. Okay, let's see from here to here. So our idea is to be one vertebra after here, up of here. But anyway, we can do an angiograph. No, we cannot do an angiograph from here. Okay.
Well, you can use the pigtail.
We can use the pigtail from here.
Yes.
And we can put digital subtraction. We can go once again to 30. And we can stay here to see where we are.
Okay.
Apnea, Carmen? Checked. Okay. So we are very close.
Yeah. Is it necessary to control cephaloric liquid in this kind of patient?
Well, in some patients, yes.
Subclavian?
But here we are not covering the subclavian, so I think it's not necessary.
It's not necessary.
Probably no. So maybe we can stay here. We can do mapping. And in this way, we can, because this catheter is too weak to stay in a position when I advance the second device.
I have a Siemens 1, if you want.
Yeah, I was thinking about use SIM, but I don't know where to conform the shape of SIM after the employment.
Okay, I have.
The other catheter we can use is a mammary, the EMA. Test. 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 Okay. This is the place. Give me uno que no sea hidrofílico. De cobra, no hidrofílico. Okay. Give me, let me, well. Okay, give me the J wire. We will try with another catheter with internal mammary or non-hydrophilic one. If we can identify better, it's going to be okay. If not, we can go there. Okay. ¿Me podés frizar la última arriba? Please. We will freeze here. Stop there. There. Ahora ponele hueso. Great. So now we have a bone marker. Okay. Let's see. If we are lucky enough with this. Double test.
Yeah.
Oh, test. A ver, oblicuo izquierda. To be sure we are on the anterior wall. More, más, more. Test. 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 There. Okay. This is okay. Okay, we will leave it there, but anyway, I know that I'm gonna lose this position. Stay there. We are okay there. Okay, so we'll prepare the 36 now or 34. Okay, perfect.
In this kind of patients, are you going to oversize 20% as we use it every day in this kind of procedures, or not?
Probably yes, but being not too much aggressive with the patients with the Marfan syndrome. You can help Franco while I am talking here. So the other issue is we are using, sorry for the noise. Once again, the free flow proximal in this case, because this patient has an aortic repair before. If not, for sure, it's going to be a patient to be treated with a non-free flow device. Moreover, we are not using too much TEVAR procedure for Marfan syndromes. Here in the hospital, most of the patients are surgery is indicated. So now I am close the device. So with this maneuver, I try to prevent any damage of the common femoral artery during retrieval. You have to be very cautious because we are going shiftless and we don't want to destroy the femoral artery. So Franco, be careful because it's gonna bleed. No, you have to hold near there. Once again, be careful.
The second product doesn't have free flow.
Yes, this second one is without free flow. So with this device, I'm going to be careful about the distal and landing zone and not so much about the proximal landing zone. Why? Because for sure we have space. We don't have to care too much about that, but this is at least the minimal overlapping that we have to have. Anyway, I think it's not going to be, we are not going to seal the whole aorta. Mostrame un poquito. So there, probably it's okay. So this one, we are going to pacing.
Yes.
180. Is that? Perfect. And now I have to open the first part. Probably it's moving. No, a 10 está la salida. Now, okay. Perfect. So now I'm going to deploy under pacing. You see, this is the movement I want to prevent when I was doing the proximal part.
And then you finish manually.
Yeah.
Okay.
This is a
We stop.
Great demonstration of why I have chosen the free flow device and not this one for the proximal landing zone. Okay. Okay. Now going to recapture. I don't know if I can. Nosecon. Now I'm going to pull it And now it's time for the angio, and we can see what's going on here. We are okay with the time. Okay, once again, aceptar.
Okay.
Don't breathe. Stop breathing.
Yeah. Okay. Más arriba, ¿no?
No, no, porque it's okay. Dale. I think we have a very nice outcome.
Yes, we have
minimal proximal
proximal
endoleak,
yes.
but we still are under anticoagulation. Let me show up the upper part. Let's see another answer. Stop breathing again. Inject. I think this is also can be porosity.
Okay.
Because we have at least 3 struts overlapping the elephant trunk. We can do a balloon in there just to be sure everything is okay.
Yeah.
And then we can leave like this.
Okay.
Yeah.
We have my 5 minutes.
We have 5 minutes, but it's okay because we have a tabby on the other room. I think we are going to be faster.
So
by
we are going
pulling
to
the
pause
wire. Let me see on AP view the distal landing zone. To be honest, I don't like to dilate. No, que no respire, Carmen. Stop breathing. Once again. I think it's perfect there. So you can observe the celiac trunk is completely open and patent. We are at the beginning of the abdominal aorta.
Anyway,
Yeah.
you have the proximal landing zone in a previous prosthesis, so it
Of
is
course.
not. So it is not
Yeah,
high risk to
no
perform a retrograde dissection.
Yeah. This is a good observation too. Okay, let's go with the balloon. We can inflate once. No,
El balón.
El balón,
elastomérico.
elastomeric balloon.
Oh, we can use a
No.
We
We are keep doing by technique without the sheet. If not, we have to use mostrarme arriba. A very big sheet is not okay for this lady. So we will do this, and then we close the groin, and I think we are done. Let's go to the left view. Please, very well diluted.
Okay. Yes.
Yes. We are not going to be too aggressive because I do believe this is porosity.
Okay.
So after anticoagulation reversion, it's going to disappear for sure. And we can show in the future the CT scan of follow-up. So we are going to pacing again. 180. Some reason we are not having a good pacing. Again. No.
Acá está bien.
Mostrame el catéter. Mostrame de frente. We will
check the
pacemaker.
The pacemaker.
It is on.
180. 180.
Salida.
Okay, that's right.
Let's go. Rápido. Stop. One more here, where we have some
Kinking.
kinking. Let me dilute a little bit more.
Okay.
Okay. Let's go once. Vamos más, una más. Okay. Stop. And one more here in the connection. Una más. Okay. Stop. We are done. Okay, lo más panorámico posible. Okay. Okay. Just one touch there. Okay. Very gentle touch there.
Yeah, yes.
And let's go. And don't breathe. Stop breathing.
We're okay.
Let's go. Beautiful. Okay.
Okay, better.
We still have some leakage there, but I think it's probably porosity because you don't see a feeling from
Proximally.
proximally. Yeah, sure. I think we are okay. We are done. Show me the AP view de frente. So now we might change the wire, Gustavo, with the J wire.
Okay. La J, ¿dónde está?
We still have some minutes here before crossing to the other room. Give me. No, it's okay there. Okay, here are okay. So light, esta es light. No la de allá. Yeah. Holding Franco. Hold. So please, Gustavo, retrieve the balloon, leaving the wire there. Okay. So now it's time to tie the knot. Revertimos por completo. Heparin reversion completely. Let me close. Okay. We are almost done. Hold it. We are tied the second one. And then we can go contralateral for balloon and so on. Yeah. Perfect. No. Here. Inside the circle. Yeah. Release. Perfect. So now Dr. Gustavo is gonna cross over with the balloon like we usually do for TAVI or any other procedure. We can hold the groin a little bit. We don't have too much bleeding, you see, just oozing.
Okay.
We wait for the heparin reversion, inflate the balloon for 3 or 4 minutes.
Okay.
And then we are done. So I think this is a very nice demonstration of the TEVAR case, a very complex case. I think all this preparation that we did before was important because it helped a lot. Yeah,
all right.
Do we agree on that?
Congratulations.
So thank you so much. I'm going to move for the second case. Thank you, Gustavo. Thank you, Franco,
Thank you.
Carmen.